Good evening, everyone, and thank you for joining us tonight. Welcome to Hunter New England Central Coast PHN's fourth Quality Improvement Community of Practice webinar on telehealth. So firstly, before we begin, I'd like to acknowledge our First Peoples and traditional custodians of all the lands we're meeting on today, wherever you might be. Pay my respects to elders past, present and emerging, and any Aboriginal people here today. So my name is Kate Dingelstad. I'm the Quality Improvement Manager at Hunter New England Central Coast PHN. And just noting before we start the webinar that we have a Quality Improvement Community of Practice at the PHN that I facilitate. If you would like access to this and all the resources in that, please contact me either by email or phone, and I'll give you information on how you can apply for access to the resources and the discussions. Please also regularly refer to Health Pathways. They have the latest news on COVID-19, and the pathways and patient information are great resources. So back to telehealth and our webinar tonight. We have two facilitators joining us from the PHN, and you'll see them on your screen. Jason Rumenaic is our Information Technology Manager for the PHN. He has over 20 years experience in IT, telehealth and digital health in the primary healthcare setting. Our second facilitator is Ross Hyam, and he's one of our fabulous primary care improvement officers in the PHN's primary care improvement portfolio. And he's a former practice manager with many, many years of experience. So tonight we're going to hear from Jason first and then Ross following. In terms of asking questions, please write these into the question or chat box on your control panel as we go, and I'll ask these at the end of each presented section. And just a reminder to mute yourself at the end, at your end, please, as well. And the last thing to mention, there'll be a survey at the end of the webinar, so please fill that in before you log off. So that's all my housekeeping. I'd like to hand over to Jason and he can start his presentation. Thanks, Jason.
Thanks very much, Kate. Good evening, everyone. As Kate said, my name's Jason Rumenaic. I've been in primary healthcare for around 20 years or thereabouts. Okay, so as I said, started around 1998 working in the primary health sector. My first role actually was putting computers on doctors' desks and teaching them to use the early versions of script writing software. So that was the very first introduction I had to primary healthcare, but since then I've had many, many experiences, including in the 2000s. We set up managed IT services specifically for general practice and allied health. That was done under the auspice of our Medicare Local, or originally Division of General Practice. From there, we ended up looking after around 120 odd general practices and around 30 odd allied health. So that gave me a really good insight into workflows and how practices actually work and function, not to mention the challenges that come with that. In the mid-2000s, we were fortunate enough to win Australian Telecommunications User Group Award, or ATUG as it's on the slideshow there, around setting up managed broadband services. Now, in the mid-2000s, broadband was still a relatively new thing for general practice. We went ahead and identified that there was some possible issues with everyone going out online and set up some managed routers, etc., which enabled us to really put security at the forefront, and privacy for that matter too. And in fact, that solution actually enabled us. We had a thing called intrusion detection system, which was put into all those routers. Now, effectively what that means in layman's term, it identifies if someone tries to hack into your system. And in fact, we did have a general practice in our area that was affected by someone trying to hack into their system. And as a result of this system, we were able to pass some details on to the police for prosecution. In 2012, and this is probably what we're here tonight for, I created a telehealth community for the Hunter region. That was done with a fairly large IT provider in the area, and effectively enabled us to set up a system along with specialist and general practice. In terms of telehealth, as an overview, the ACI's definition is around telehealth is the delivery of healthcare at a distance using information communications technology. Now, most of you, I suspect, have been doing this already, either via a telephone or possibly even by video. But implementing telehealth in general practice, there's a couple of things that you need to think about. Most people will attack these problems or these implementations with thinking it's purely a technology implementation. Now, it is actually more importantly a change management implementation. The technology is merely an enabler for that. Obviously, COVID-19 has been a key driver in telehealth uptake in the region, or Australia-wide for that matter. And also MBS billing changes have also been a key driver. Ways of delivering, as I mentioned, is telephone, which I'm sure you're all aware of. There are other options along with video conferencing, such as store and forwards, such as email or secure messaging, and obviously things like remote monitoring devices, such as wearable devices, smartphone apps that collect patient measures. There's also website and application apps. Of note, if you've been involved or been approached by your PCIO around a capacity tracker, that effectively is a form of a telehealth solution to a website or an app. Privacy of telehealth. Now, there's a whole bunch of literature out there from the RACGP or ACI. There's obviously privacy legislation we need to adhere to. I thought I'd throw a few of the probably ones that may get missed from time to time in tonight's meeting, and that is around looking at security of the software, or both hardware and software, and looking at the interface of that video conferencing system. Now, tonight we're using a product called GoToWebinar. That particular product is purely a almost one-way transmission. However, it's also a software system that potentially goes offshore, and secondly, when it leaves the servers in this country, we actually can't control where that goes. And there's other products out there that have had some well-documented issues around that. Another thing in general practice that is worth considering is if you do store any images or videos, typically from products even such as GoTo, if I was to store a snapshot of a screen capture or something like that, it's actually going to store it locally on my computer. Now, if my computer is replaced and it's not wiped correctly, those snapshots or pictures or videos potentially could be released by someone if they were to get hold of the computer. Visual and audio privacy of the room is another important thing. I have sat in practices in the past where the walls have been fairly thin, and when someone's in there consulting, you can actually hear everything from the waiting room. So that's something worth considering. If you're sending email appointments out to people or text messages via SMS, it's worth confirming those email addresses and mobile phone numbers. Now, I regularly see that happen by front desk staff at practices, but it's just worth sort of touching on that. If you're sending an email, sometimes it's also worth following up with a, please reply if you receive this, just to make sure it has been sent. Again, I've had emails sent to me in error that potentially were to be sent to a patient or to another provider, where someone has just simply started typing in Outlook or whatever, and they've started typing an address, and my address has come up because it's been cached in the application. So it's certainly worth considering. Telehealth video conferencing. So key components, I'm sure you're most aware of this, but I thought I'd go over it nonetheless. And that are things, obviously you need a computer and a laptop, that's a given. Cameras or webcams, I'm sure if you have tried to purchase any telehealth equipment recently, you've seen that stuff is actually being quite hard to come by, purely for the fact that the rest of the country has decided to work from home and have decided to do online meetings. A headset is also another thing that I find it's better than using a laptop or an outside microphone, purely for the fact that you actually get better clarity of sound, and also the microphones are a little better. So therefore, the patient can actually hear you a lot better. Other methods obviously include things like tablets and smartphones, and certainly I've heard anecdotally of a lot of practices using those things over recent times. when we look at software, some key software considerations, the first and foremost thing to think about is, does it suit your clinical needs? Again, using GoTo product that we're using here tonight, it's probably not ideal for a surgery to use or a practice to use, and purely because it doesn't have some of the features that I've also listed in this slide, things like a waiting room, the screen sharing, yes, it does. Yes, it records, but the privacy thing, it probably doesn't quite meet standards. And also budget. These products can be inherently expensive, and so you need to consider that obviously as well. What I have done here in this slide, and you'll all have access to a copy of these slides, so don't worry about trying to jot down the URLs that I've attached, but there's a whole bunch of applications that are widely used in telehealth. Health Direct Video Call, which I'll talk about a little bit later, GP consults, CoView, which is actually the product that powers the Health Direct Video Call system. Attend Anywhere is another product that's actually been used widely overseas as well. It's actually developed in Melbourne, but is another product that has been used, as I said, over in the UK in particular. Scopia and Pexit, now they're products that are used by particularly our local health districts. So a lot of our hospital services are using those products, and that is purely because it's easy to connect to external people that aren't part of your regular network or, you know, outside the hospital firewalls. I've also put in Skype for Business, or Microsoft Teams as it's becoming. That's a product we use at Hunter New England Central Coast PHN. It's a product that is secure, it's safe. However, one of the downsides to it for me is you do need to have an Office 365 license. And I do appreciate that a lot of general practices don't have those licensing. In terms of PHN assistance around telehealth, there's a couple of things we're doing at the moment. One of the things, and you'll be the first to hear about this, is we've development of a support and recommendations paper to go to the Department of Health, and it's on behalf of New South Wales and ACT PHNs. This paper is really designed around the continuation of telehealth support for practices going forward, post the September cutoff date with the current MBS items. In this, we've put some major recommendations together. Some of these include to continue all current MBS items relating to telehealth across all patients and geographies. So that gets away from the previous restrictions around telehealth was really more for the country areas and not so much for the city areas. Also access to MBS items relating to telehealth by all primary care types. So that's not just general practice, but also things like after hours, etc. And also compulsory bulk billing for under 16s and the vulnerable groups. In converse to that, I guess we've put in the removing compulsory bulk billing for groups apart from those vulnerable groups and under 16s, purely because it's been acknowledged, and I think we've done some surveying of late that actually have shown up that for telehealth to be sustainable, there needs to be potentially some co-contributions from patients or a billing methodology applied. Also, to add active patient criteria for some primary care sectors with some flexibility. Now that really talks about more things like, so under the current rules, you need to be a patient that's seen in the practice, I think it's 3 times in the last 12 months, or 2 years, sorry. And then that counts out things like after hours services. So we want some flexibility in there to include after hours care also. Also to consider the options of maximum number of telehealth appointments face-to-face or versus face-to-face. That's basically, we're aware that if telehealth was to be an open slather, there may be an opportunity for people just to try and set up telehealth only businesses. Now, we don't see that as being good for patient care, as well as obviously for general practice. So we'd like to make sure there's some, I guess, constraints in there. And also to consider the expanding of MBS items for allied health providers as well. So as I mentioned a little bit earlier, the Health Direct video call platform, we at the PHN have worked with Health Direct to be able to provide that free to general practice. That is for a set period of time. However, part of the paper that I just previously talked about will also be asking for that to be expanded and continued on for a period of 24 months. If you're interested in a platform, you can send an email to telehealth@hneccphn.com.au. That will hit my IT officer, who will be able to get in touch with you and provide you some further information, whether it be training information, give you a bit of an overview of the system, as well as get you registered if you're interested. We, as I said, supply training material. There's a whole bunch of PDFs. There's things you can send out to patients to make it easier for them, as well as there's some really nice videos that show you how the product works. We've also added in our website a telehealth section, and we also have engaged with our IT provider to enable a hardware portal for you to potentially purchase webcams, headsets, those kind of things that I talked about earlier, if you are interested. Or if your current IT providers cannot provide. So just on the video call stuff, this kind of goes through, this slide goes through the step-by-step for a GP. It's fairly straightforward. The GP, it's a web-based system, so the GP would log on to the system. Now, again, this day and age with all of the web browsers, etc., you have the ability to save usernames and passwords into those, so you don't need to type that in every time you see a patient. It takes you to a waiting area. From there, you can select the patient and then basically join the call. That's as simple as it is, to be honest. And that's the GP side of thing. I also have one from the patient side. Again, some practices that have websites have put their waiting room up on their website. So you just direct the patient to your website. Others have actually been sending SMSs out with the link. Some have been sending emails out with the link to the patient's video call service. Once there, it takes you to a small registration page where they simply type their name and phone number, and that's purely to identify you in the waiting room as a patient. From there, the clinician arrives and the call starts. So it is relatively simple even for patients. As I mentioned, on our website, we've got a telehealth microsite set up. Again, I've just listed on there how you can get to it. So if you go to our website, there's a coronavirus COVID-19 section. There's a latest information tab you can click on, or button you can click on, sorry. From there, there's a read more. If you select that, it will open up a list of things that are related to COVID-19, including things like health pathways that Kate mentioned earlier. From there, there's a telehealth heading, and then underneath that, there's a telehealth microsite that you can select. On the right is a bit of a, and it's probably hard for you to see, I appreciate that. That's kind of what the page looks like. It has some sections on primary care, some stuff on the video call, some videos, as well as link to resources. Also, if you happen to be a registered user of our capacity tracker system that we've recently launched, there's also a resource center in there that also has a telehealth section, which contains effectively the same information. This slide is just simply a bit of an overview of the telehealth portal for hardware that I talked about a little bit earlier. Again, I don't expect you necessarily to write down the link or be able to necessarily read everything. It's more just to show you what it looks like. So if you do get to it, you know you're in the right spot. Again, the slides will be shared so you'll be able to have a closer look also. Before I just finish up, the one thing I will just mention just about that portal, and I did say it earlier around the fact that there are very many people out there buying webcams and cameras and headsets up left, right and center. If you go to that portal and it does say it's out of stock, you still can purchase it. It just simply goes on to back order and then it will get shipped to you when the product does arrive. In fact, from about next week, I believe, stock should start coming in, and that's not just for this portal, but I expect all stores will start to see a little bit more stock around webcams and headsets. If you have any questions, as Kate said, you can put in the chat box. If you think of one later, you can reach me at it@hneccphn.com.au, or you can call me directly on 0240885905. Thank you very much for listening.
Thank you, Jason. We have had one question come through on the chat pain. So I'll just
Yep.
tell you that. Is there a health pathway that contains some of this telehealth information?
Yes, there is. There is a telehealth health pathway.
Yeah. The next question, I've heard of people using FaceTime for telehealth. Is that secure?
It's not secure as such. The other issue you have with FaceTime or some of those type products is you're only able to talk to people that have either an Apple device or a Samsung device, depending on what type of system you use. So you kind of limit who you can actually see. Ideally, what I'd like to see is a product like the ones I listed earlier. And ideally, what we'd like, I think, even as a patient, I'd like to have the same system for all providers. And that way, as a patient, if I've got chronic disease and I have to see a dietitian, maybe a diabetes educator, a specialist, a GP, I'd like to use the one system for all. That would be perfect in my world.
All right, we've exhausted the questions that are currently listed. Is anyone else interested in asking a question? You just need to click on your chat pane or your questions pane on the control panel and type in your question, and that will come to me and I'll ask Jason. If I don't hear anything in the next couple of minutes, what we'll do is also keep Jason around until the end of Ross's presentation, so that if you think of something in the meantime, you can also ask it at the end of the webinar. Here we go, off the topic. What do you think about a cloud-based practice for storage and running software?
Cloud-based is fine. In fact, to give you an idea, our PHN is fully cloud-based. The key thing for cloud-based is effectively a good internet connection, having some redundancy around that internet connection, so having a way that you potentially can connect if the internet does go down. And then the obvious one around privacy is purely making sure that the stuff is stored in Australia, not overseas.
The next one is probably a question for our next presenter, Ross. Is there an item number for after hours? And Ross is actually going to cover off MBS items in the next presentation. So we might hold that one until the end of the next presentation. Any other questions? With sending emails, what's your recommendation for securing privacy?
So emails, firstly, should not contain any health information in them because they're not secure and it is a breach of privacy. If you do want to send clinical information, you should use secure messaging. If you are sending an email such as an appointment time with a web link to the waiting room or something like that, as I said, getting a reply back from the user is a good way of actually ensuring that the message has arrived to its intended recipient. The other thing is obviously a disclaimer down the bottom of your email saying, hey, if you're not the intended recipient, don't read it, don't forward on. And there's a whole bunch of examples of that on the internet that you can use.
All right, thanks, Jason. Does the Health Direct video call have any advantages over GP consults?
I think they're very similar products. I wouldn't say there's any real advantages over them other than maybe currently the cost. Currently, Health Direct video call is free. And as I said, we are advocating for that to continue to be free for 2 years.
It's a good reason. All right, I think that might be it. Yeah, that's all one more. When you say secure messaging, what would you use for sending to patients, though?
So if you're emailing to patients, obviously you can't use secure messaging. So therefore you will need to send email, and you can actually send encrypted email, in which case you need to provide a password to the patient to open that encrypted email. However, depending on the content of the email, if you are sending clinical information, you can also ask for a reply to say they've received it. That's another possibility that you can do, because it shows at least then you've used your best efforts to ensure that the email containing that information has arrived at the recipient it's intended for.
All right, do we have a template on privacy for telehealth?
A template? That's a very good question. So the PHN themselves have not developed any templates, but certainly the RACGP and the ACI telehealth resources will have some information in there on privacy. they're probably where I would point you to for that.
All right, thanks, Jason. We might hold those questions there. If you have any more, please feel free to ask them at the end of Ross's presentation as well. But thank you for your time tonight, Jason. We'll ask you to just hang around until the end and open the floor for questions again. I'm just going to change presenter across to Ross. And Ross, if you would like to share your webcam. All right. Oh, he's disappeared. Oh, there he is. Hi, Ross.
Hi, Kate. How you going?
Okay, great. Just making sure we can hear you. All right, would you like to head on with your presentation? Thank you for joining us tonight and sharing your expertise. We can see your internet screen at the moment. Okay, great.
How's that? Is that
fabulous? Thank you. I'll hand over to you. Yep.
Terrific. Hello, everyone. My name's Ross Hyam. I'm a PCIO based in Scone. I cover the Upper Hunter through to Newcastle area. The quality improvement activity we're going to consider is getting practices and their patients to have more video consultations. We'll be using telehealth MBS items as our measure of that improvement. So Kate's given you a bit of an introduction. I was practice manager at Scone Medical Practice for 26 years and have been with the PHN as a primary care improvement officer for the past 18 months. The highlight of my practice managers years was the Scone practice being awarded the RACGP New South Wales Practice of the Year in 2016. However, there were also many years where we struggled to recruit doctors like many other practices. So it's not all glory. There's a lot of hard work, as I appreciate, for practice managers and practice staff involved in keeping a practice running. Prior to that, I worked with the Commonwealth Bank and the Bayswater Power Station in various roles. I was born in Narrabri. I lived there until I went to high school at Tamworth. And then from there, I worked in the Commonwealth Bank and went from Nelson Bay to Singleton to Muswellbrook to Foster and to finally Scone. So that's enough about me. Let's get on with the show. The majority of telehealth consultations are being done by phone. So we want to change that as we believe better patient care and outcomes can be attained by having video consultations more often in general practice. For the purpose of this activity, a telehealth platform is already installed at the practice, so we're not going to go through that side of things. Jason's done that in his discussions, and we'll just focus on a system that's set up and just trying to get our patients to do video consultations rather than telephone. So that'll improve patient understanding of the system and also involving improving our practice systems to incorporate video conferencing in that and identifying the correct item numbers to bill. So let's start with the telehealth items for consultation. So we're only going to look at the consultations only because we're trying to keep this as simple as possible. And no doubt you'll be familiar with most of these items. So we're going to, as I said before, we're going to use this as our measure of the quality improvement activity. So you've got your short or obvious attendance for problem, which is in item 3 with a separate telehealth item for video and a separate one for telephone, and that works through to items 23, 36 and 44. So the one thing about the MBS items, they are all the same. Conditions apply to whether they're video, telephone or face-to-face, so that doesn't change. But there is a provision that these items must be bulk billed for vulnerable patients, concession card holders and children under 16 years. That's the only difference between your 3 and your telehealth items. Now, who is a vulnerable patient? Now, this does change from time to time, so you need to keep up to date with these changes. You've got your standard set of criteria there. So someone is required to self-isolate. I won't read all these. You would have recognised all these from your using them in general practice. And then the ones that change is the ones that meet the current national triage protocol criteria, which seems to be the one that they change according to what's happening at the time with the COVID-19. So included in that at the current, as it currently stands, are aged care and other residential care facilities, military personnel, those who are in the Navy, obviously accommodated in ships, which is a close-knit community, and accommodation in barracks and that sort of thing, boarding schools, detention centres, correctional facilities, Aboriginal Torres Strait Islander rural and remote communities, and in certain places where they've had an outbreak of COVID-19. Now, as I said before, the bulk billing incentives are compulsory for those telehealth items for patients who meet the clinical criteria for being a patient that needs to be bulk billed. That is the under 16 and concession card holders and the vulnerable patients. So you have items 10990 and 10991, which were existing prior to COVID. They were meant for the under 16 patients and those who were concession card holders. Two new items were introduced, which is the 10981 and the 10982 for the vulnerable patients that didn't meet those other two criteria. So that's the difference between the two. Now let's start the quality improvement activity. I hope that you're all familiar with the PHN model for improvement template. I've just modified this a little bit with the heading out to the left-hand side rather than being on top, just so it fits on the slide more effectively. So this is where we develop our ideas for our quality improvement activity, starting with our goal setting, which is broken into 3 questions. First one is, what are we trying to accomplish? That's obviously by answering this question, you'll develop your goal for the improvement. The second is, how will we know that there is a change in an improvement? So this is where we develop our method of measuring the success or otherwise of our improvement activity. And the third one is, what changes can we make that can lead to improvement? So these are just ideas that we put forward in trying to achieve our ultimate goal. So we just started this activity that we've decided we're going to do. So we put our first, what we're trying to accomplish is improve patient care by video telehealth consultations to minimise risk of COVID-19 infection to patients and staff. Our second question is measuring the change. How will we know that a change is an improvement? And we're going to measure that by the number of video consultation items built in the practice software. Now, measurement does not always have to be quantitative, as it is in this occasion. It can also be qualitative, such as a satisfaction survey results or a combination of both. So if you're just trying to determine what people think of a process, that can also be part of your measurement. So let's move on to the ideas for this improvement activity that we're going to do. Now, each idea will impact on the progression of achieving our improvement target. These are the steps in the process. So our first idea is to organise the team responsible for the activity. So we have a staff meeting to organise the team to conduct that activity. Our second idea is that team is to develop practice procedures and training for staff and patients. The third idea that we have is the staff training of those procedures. And the fourth one is to encourage patients to participate in video consultations. So now we move on to the next stage of the process, which is the actual Plan, Do, Study, Act, or the PDSA cycle. For the purpose of this presentation, we're going to look at the fourth idea we had from the previous slide. which is to educate patients to use video consultations. Now that we've got that idea, now we've got to do our plan, which is what needs to be undertaken to start the activity, who is responsible, when and where is going to happen, and how are we going to measure that activity. The next stage is the do, which is the mechanics of how we are going to implement our idea. What steps are required to achieve success of our ideas? Study is the reflection, which is the third process in this line, is reflection on what happened. We rerun our baseline report to compare to our original data. Did we achieve what we set out to do? And the final part is the act part, is where do we go from here? Can we improve improvement by new ideas or modifying the ideas used in our PDSA? Or have we just succeeded and we just carry on as usual? Now let's start with the planning stage. So who is going to be involved in this event? You'll have your team organised in the idea one. So remember, we've had 4 ideas. So the first part of the plan, first idea one was to organise your team. So that team is going to be running this process. The starting date, well, we can start today if you like, or whenever you start the thing, where it's going to be at the practice, and the data, oops, we've gone on. And the data, how are we going to measure the success of the activity? So we're going to generate a report from the practice software of all the telehealth consultations billed for the previous month. And what we're going to do then is aim for an increase of 10% of the total telehealth consultations to be video consultations over the next month. And that's what what we'll do at the end of this period is run that report again to check to see that all works fine. So just to have a bit of an idea of what a report would look like and just keeping it nice and simple, this is just using those telehealth items before. You got your video group, which is the 91790, 91800, etc. So when we ran our report, there were 20 patients who had video telehealth consultations. And then comparing that to our 91795, etc., which are the phone telehealth consultations, 480. So there was 20 out of the total of 500, which is 4%. Was what is the number of patients we're starting with in this. So our project target is 10%, which would be in this circumstance 50 video health consultations. So is this a SMART goal, which is specific? We've asked for a 10% increase, so we've been very specific about that. Measurable, we've got our report on data before and after. Attainable, currently it's 4%. I think that's a reasonable increase that we've asked. We've gone on these numbers from 20 to 50. It's definitely attainable, realistic. We're not going for a dramatic increase, and we're limiting it to 1 month. So that's a reasonable time frame to achieve that situation. So how are we going to do it? So we're going to, in this circumstance, and this is not an exhaustive list. You can play. This is the part where you can play with. If you don't succeed with your idea, well, you can modify this section of your plan to try other avenues, and therefore you start a new PDSA cycle if things don't work out as you want, or you think there's ways of improving that you could test the waters as well. So in this case, we're going to develop a sales pitch. We're going to determine patient capability of using telehealth platforms. So this is important. If they haven't got that capability, they're not going to be able to use video consults. We've got to make sure that their email and mobile phone numbers are current, because that's how we're going to be contacting the patient. We're going to have someone trained, which I think which we would have identified in our idea number 3 when we're talking about training of staff. so that they can help the patients use the video telehealth program. We're going to develop a checklist to ensure that patients understand the process and to make sure that they're confident with what we're doing and what they're doing to achieve a good outcome, and create or use an existing patient education brochure for display in the practice website or social media if we have that platform. So what about some ideas for advertising? You can advise patients when they're making appointments. You can have an automated telephone message while they're on hold, for example, saying, we have video telehealth appointments available. Waiting room posters, consulting room posters, information on your web page, an online appointment option, or even a social media post if you use that as well. And you can add your own ideas to this. This is just some ideas that I've had. The sales pitch. This is where we want to try and encourage people to get into the video conferencing. So what I've developed here is a quick overview and just based it on ideas of transport. For those patients who have mobility problems or transport difficulties, it's got to be a good option for them. Travel time, waiting time for your professional business persons and just employed persons. If they don't have to leave work to go to a doctor's appointment, it's great productivity increases for their employers. So it's a win-win on two parties there. And one of the important things we know with the flu season, all that coming up, it minimises the risk of infection to patients and staff during infection periods. And if you've got someone, if you're on holidays and you've got a regular doctor appointment, you can still have that appointment while on holidays just by doing a video conferencing. Ease of use, most importantly, if you have a staff member to guide the patient through that process, it just makes it a little bit more comfortable for them. And, it's more personable than a telephone consultation, which most patients look forward to. Now, for the patient, we also want to have to give them a checklist so they can guide them through the process. And it's probably, besides giving them a checklist, it's probably a good idea to do a test run before the consultation staff, have your dedicated staff member to do that. And so that any issues that arise can be detected and remedied before they so it doesn't waste the doctor's time or their health clinician's time. It just makes everything run a bit smoother. So what the patient does need, though, is a dedicated private area just for privacy reasons. Minimise distractions, don't have the dog running around the house or children getting in the road. Ensuring that the telehealth platform, as we said, is working. Have practice, and it's also contact information if something goes wrong, so that if they recognise the problem before the staff member helps them, they can actually contact the practice and say, look, I'm having issues with this. And that they're prepared for the consultation, so they have a list of their medications, problems, etc. And they have the ability to take notes so that they know so they can remember what the doctor tells them they've got to do. Now, this is just a slide put out by the Quality Practice Accreditation or QPA resource, and it's also to help patients. It just takes through the patients through their involvement with the video conference. There's a link at the bottom of the page there, which as you'll have access to these slides after the presentation, and it's just save you doing the job of creating the similar type information sheet. There's plenty out there available which can do the same thing. The next slide is the study and act part of the cycle. So we're getting towards the end of the cycle. We've done our plan, we've done our do. Now we're doing the study part, which is looking at the results and did we achieve the desired outcome. So in this case, we, as I said previously, we'll rerun the report that we started with and then just compare the previous report to this report using exactly the same data, just using a different period to the current period that we're working with rather than the previous period that we started with. And it's always a good idea to get patient and staff feedback in this process as well, because there's things that don't get picked up out of reports, but you know, your staff who are dealing with patients and organising these video conferencing will know what questions the patients will be asking them, and that could be something that could help improve further ways we do things in the practice. And the final stage is the act stage, is can we improve by changing this process? This would normally involve changes in the do part as previously mentioned, and that we would redo the PDSA again with the new ideas. If everything's a success, we can just move on. So this is just a comparative report we've done after the event. In this case, our project target was 10%. And what do you know? We've got 400 total telehealth consultations and 40 of them were video, which is exactly what we wanted. We could, even though we reached our target, we could go back and refine the process, or we can just accept that and move on and have this as business as usual. Now we just run these slides. This is just what the finished product looks like. You've got your goal setting, quality improvement activity. Then you've got your planned PDSA cycle, going through the whole process, and finally the ACT part of it. And that's the end of the process. These are the references and resources that are available. The RACGP also have, I didn't get to put that on there, but the RACGP also have coronavirus resources as well, which includes telehealth processes. And that's the end of the slides.
Thank you very much, Ross. That was excellent. Okay, I might get Jason to also join us by webcam, if you wouldn't mind. Keen to hear about after hours MBS item numbers. Ross, can you comment on that?
There are MBS item numbers. The equivalents to the item numbers 599 and 600, which are the anti-sociable hours. There are COVID ones. I think I'll just try to find them while I was quickly doing this. 92210 for the video and 92216 for the telephone. That's for the 599, and I forget the other one, but it's pretty much the same. But there are, if you go to the MBS item numbers, like MBS online, you can actually look up the item numbers pretty easily. Just put in telehealth, and that search will incorporate all those certain item numbers that are involved with that.
Okay, this one's probably for you, Jason. Can we use the Scopia? Can we use Scopia via H&E Health in the community?
That's a question probably for H&E Health. I don't believe you can, because I think they initiate the call, so it's for their clinicians. And again, this is my understanding. They initiate the call from within their network out to either doctors and all patients. So you would need, I think, your own license to do that.
Sorry, Jason. Yeah, being part of a practice, yeah, that's the standard procedure. They send you a link, or they send you the program to start with, and then you just link up with them. It's all governed from the health district.
Righto, thank you. Another question about item numbers. What about for standard consultations at after hours for item numbers?
That's
similar.
What we were talking about before, yeah.
Yeah. Okay, forgive me if I haven't got that right. Please rewrite the question if I haven't answered it. All right, do you have any suggestion to get doctors on board with telehealth? I find a few that I work with or work for are not a fan of it. They will do telephone consultations if they have to, but have mentioned they prefer face-to-face. So it's about that case for change and getting people to change their behaviour, I guess. Any tips?
That's Well, I think there's just a confidence level with the security of the system, privacy and security of the system. I think was the basic things that most GPs or healthcare providers are concerned with. But most programs, if they're suitable and pass the like Health Direct and those sort of programs who have their own waiting rooms and are fairly safe, well, it should be quite feasible for the practitioners to do telehealth consultations. You know, what tips? I don't know. You've really got to know them, I suppose, to try and convince them to do it. I don't know if Jason knows anything with his.
Well, I guess I might have something to add there, you know, as a change manager, but I guess it would be down to demonstrating how easy it is to use a tool like this, and getting that anxiety around managing the system out of the way. So sitting down with somebody, spending some time, if they have it, understanding that GPs are very, very busy people, and just trying to allay some of their fears. But Jason, did you have some comments there as well?
Yeah, the first thing I'd say is you need to reassure those GPs that you're not expecting them to do every consultation this way. There are certain consultations where telehealth is not appropriate. But for something like potentially a repeat script of a patient that you know very well, and you know that the script is a fairly routine thing that you would do, that might be a really good starting point. The other thing, and you kind of touched on it, and that's just doing some test calls in that. So when you get access to a system, there's no reason you can't play around with the system in-house and do a few test calls and see how it works.
Yes, we did that for this call just last week. Thanks, Jason. Another one here, just a comment from one of our attendees, the health pathways on telehealth contains all the links to relevant MBS item number information. So it's also there as well as being on the MBS site. Is there something equivalent to item number 5020 instead of unsociable hours, i.e. 8 p.m. or weekends? Did we know that?
I'd have to check that one up. I'm not aware of that one, no, Kate. I'm
not either. So maybe for the person who asked that question, just check health pathways or go to the MBS site for that. Do doctors need to get verbal consent before a telephone consult?
Always a good idea to get a consent in any circumstance that a patient doesn't sign something. I think that's for, you know, whether we're going to bill them at the end or you're going to do some form of treatment. The consent and documented in the medical record. That's the general rule of thumb.
Yes. All right, there's another one.
RSCGP, sorry, Kate. The RSCGP does put out a lot of telehealth brochures and things for clinicians as well as patients. So it's probably worthwhile going to the RSCGP site, and they've got all that sort of thing documented there.
And another comment, if a clinician is really struggling with doing a video consult, just in terms of not being familiar with the technology or being a bit concerned about that, then it's always a good idea to sit down with them and maybe get them started with the patient and then disappear, you know, to avoid privacy issues. Yep. I like your list of things to attract patients and get them on board with telehealth. I think that would help with GPs too. It means that many of the things that we might do for free, we can now get paid for, e.g. results. That's a good comment.
I think that, that QPA brochure that I had up there, they have one for clinicians as well. I think they've got that in the resources at the end of the presentation. So it might be handy passing that on to your clinician if he's a little bit worried about doing them.
For sure. There's some helpful links that have been posted in terms of patient consent. There's MBS online link that I'll pop in the information that we post following the webinar. The telehealth item number for after hours is only for unsociable hours. We've had another PCIO chime in with that. Thank you, Heidi. And you've said that using email is not acceptable. What are your suggestions regarding sending information to patients, e.g. medical certificates, information sheets, referral letters? Jason, I think that one might be for you.
So referral letters, let me start with the other one. A certificate doesn't actually contain medical information as such. So you're not sending anything that is in breach of the Privacy Act. And a referral letter, again, is generally a condition along to a reference to where you're being referred to. So again, that's not breaching the Privacy Act also. Sending health results as such, sending blood test results, that kind of stuff, that's where you're potentially breaching the Privacy Act by sending via email. In fact, the RACGP computer guidelines have stated that email is definitely not allowed for the sending of those results.
Okay, thank you, Jason. That's coming to the end of the questions that are listed here. I'll just give people a few moments just in case they have anything else that they'd like to ask. And check the chat pane as well. Can scripts be sent via text message to a patient?
Not under the current set up. So electronic prescribing is a fairly hot topic at the moment. It's something that was first done several years ago, but really until COVID-19 turned up, there hadn't been a lot of progress. Recently, they've allowed to send electronic scripts from a practice to a pharmacy, in which case a QR code gets sent to a patient, which they can turn up and then get that QR code read and a script issued.
Yeah. At the moment, that's where we're at, but it is certainly on everyone's agenda.
Yeah, or otherwise they can actually send. They did make a provision so you could send emails. Emails to the pharmacy or fax scripts to pharmacies to get them filled. Preferred fax rather than email.
Is there a recommended email encrypted service?
No.
No.
I would be recommending, firstly, secure messaging. Secondly, I'd be recommending that we're not sending patients directly clinical information via email, full stop.
Yep. Okay, moving on. Would imaging request or pathology requests be suitable to send via email? Just the request, not the result? Just in terms of our previous conversation.
Yes. Ultimately, we send referrals, pathology requests via mail, and that's snail mail, so to speak. So sending that stuff via email, again, ensuring that you've checked that the recipient address is correct and you've asked for a reply to see that they've received it, means you've made best effort.
Yeah. We've also had a comment that New South Wales Government has specific information on how doctors should be sending these things. So doctors to send digital scripts to pharmacists. Text messaging is not okay. What we've discussed essentially is where it's at the moment. Obviously, the world is moving very quickly in this space. The PHM will be holding a mastermind. Oh yes, the PHM will be holding a mastermind meeting on e-prescription in the coming weeks. And that's from Charles, who is another one of our amazing PCIOs in our PHN. Thanks, Charles. And that's all we have at the moment. Any further questions from the audience? One more. If you advise the patient that emailing is not secure, and you comment in it that their medical file, comment on it in their medical file, would you consider to send by email? Let me start that one again. If you advise the patient that emailing is not secure and you comment on that in their medical file, would you consider it okay to send by email?
No.
No. No. If you've advised the patient that emailing is not secure, then you don't. If that's your status.
Yeah, you may have advised the patient, but at the end of the day, you've not made best efforts to ensure that is securely transmitted from point A to point B.
Yeah.
You probably have to go back to the old snail mail.
Yes.
Under those circumstances.
Yeah. All right. Well, we're bang on 8 o'clock, so I'm going to finish our webinar there. I'd like to thank you, Ross, very much for your presentation and time tonight, and also to you, Jason, for your presentation and time. Really appreciated your expertise and your knowledge in this area. And thank you to everybody else who's attended tonight. If you would like to join the community of practice for quality improvement in primary care, please send me an email. My email address is actually listed in the chat pane, so you'll be able to get it there, or get in touch with the PHN and they'll put you through to me. So thank you for coming, and we'll see you next time. Thanks, everybody.
Thank you. Bye, everyone.
Thanks.
Good night.
Bye.